channel. So today we are going to go through internal medicine history taking and physical examination findings, questions as well as answers. So the reason is that we want to, because when we're taking history internal medicine, the thing is we have to know what questions to ask depending on the symptoms that you have been given. So there we can start. Okay, so for station 1 is saying a 41-year-old man presents with chest pains. Take a history and ask important questions that will enable you to make a diagnosis. So these questions, don't write an essay. Okay, so you have to note that for a physical ask, you have to introduce yourself and you greet the patient and you gain consent and ask about demographics, and don't forget to thank the patient after you are done, even if you are not yet finished. Okay, so you usually use Socrates if you are dealing with anything that is related to pain. Okay, so you ask where is the pain? Can you point to where you experience the pain? For the onset, we ask when did the pain start, and is it sudden or gradual? Also, is it progressive or regressive? Okay, and for the character, you ask how would you describe the pain? Is it constant or does it come and go? Okay, for the radiation, ask does the pain spread elsewhere? Okay, then as any associations, you can ask any sign and symptoms associated with the pain. So when you ask someone like this, if they say no, you are now supposed to point them toward your own questions. So depending on the system that you are talking about. So if you ask the main associated symptom with the pain, if they say they don't think they don't know what you are talking about, you can say, okay, do you have any cough, hemoptysis or weight loss, dizziness, shortness of breath, dyspnea, palpitations, fever, orthopnea, PND. So you point them toward your questions, the one you think are associated with the chest pains. So now chest pains can be cardiovascular in origin or respiratory in origin. So that's why we find that even the questions that are associated can be both. That's why on associated symptoms, you also ask the cardiovascular and respiratory questions on associated symptoms. Okay, so that's the thing about that. Then for the time course, does the pain follow in pattern or how has it changed over time? Are there any exacerbating or relieving factors? So does anything change the pain or from worse or better? Okay, then for severity, how bad is the pain on a scale of 0 to 10? 0 being no pain and 10 being the worst pain you have experienced. And does the pain affect your daily activities? Now, for severity of pain, for me personally, the reason why I don't like to use the severity of the pain, telling them to scale the pain from 0 to 10, is that for pain, the thing is, if you ask me how is the pain, and I can just tell you 10 or 8, like something like I'm going to grade it to a certain level, but when you are assessing me, you can actually just say, okay, the pain is mild, moderate, or severe, you yourself. Because if you ask me to grade it, I'm not necessarily going to give you an actual figure. I would like to exaggerate a bit so that I know that, okay, it's serious. Okay, so that's the thing. So for the past medical history, you ask for any history of HIV, TB, pneumonia, asthma, or lung cancer. Okay, then so the past medical history is relevant. So it's relevant to how someone was presented. So what condition am I going to ask that can present with chest pains under past medical history? So drug history, any current medications or current allergies. Then family history, any family history of asthma, any family history of TB. So some of the relevant questions. Then for social history, we ask for any history of smoking. If yes, ask the duration and number of cigarettes per day. So, and even the type as well. So you are even asked the type of cigarettes. Then for the occupational history, you ask where do you work, if it's an outfield worker or miner. So you might be dealing with an occupational lung disease. That's the importance of asking these questions. So that's typically everything we wanted to share on this particularly. Okay, so that's the end of the station. So we are now on station 2. Okay, so meaning we are done asking these in 5 minutes. So even make sure if you are doing the long case or short case, you have to be fast. You have to know which questions am I going to ask under family history or past medical history. Don't just ask anyhow. You have to know, okay, what are the relevant questions and past medical conditions in past medical history am I going to ask, because you can't just be asking any questions that comes to your mind. No, you ask questions that are relevant to the condition, to the scenario that you have been given. Okay, then another scenario which is saying a 46-year-old presents with diarrhea. Then get a relevant history and ask important questions that will enable you to make a diagnosis. So you have to list the questions and should you write an essay. So you have to know that the same for the diagnostic stations, the same thing we talked about. You have to introduce yourself, greet the patient, gain consent, and don't forget to thank the patient after you are done, even if you have not yet finished. So demographics, of course, start with the demographics. Where do you stay? Uh, where do you work? You can even ask it, but if you ask where someone stays, then there's no need of you asking them in the social history. Okay, that's how it is. Okay, then presenting complaints, which we have been given is the diarrhea. So we ask, when did the diarrhea first start? That's the duration. Okay, when did it start? How long has it been there? How long has it been there for? Then how often has it happened? Then after you ask that, then next thing is you can ask how often has it happened. Then do you have diarrhea at night? Okay. Then is there any blood or mucus in stool? So if they say no, ask them, okay, it's meaning it's watery then. Okay, is it water? So is it watery if they refuse the blood or mucus in stool? They ask, if they just say it's watery, yeah, then that's the consistency of the diarrhea. Then is there any abdominal pain? So this is now an associated symptom. So is there any abdominal pain, nausea, or vomiting? So if yes, is there blood, or how many times, and what is the nature of the vomiters? Okay, how about abdominal bloating? So is there abdominal bloating, out pain, or tenesmus? These are some of the associated symptoms we are going to ask. Okay, then when and where was the last meal? Then what was the last meal? Did it contain milk or dairy products or sugar? Any associated fever, any association with a specific meal? How is the water sanitation and food cooking skills? So when we say when and where, the reason why we are asking about where is because if the patient went to a party, then that's where they last ate the food. Okay, if they bought street food from the streets, that's an important thing to know. So that's how it is. So you have to ask where the last meal was. Okay, before the diarrhea started. So that's a very good question to ask. Then for the past medical history of you have to ask for any history of HIV. You have to ask any malabsorption syndromes or any history of abdominal surgery. So these are specific to what we have been given, which is the diarrhea. For drug history, any medication they are taking or any drug allergies. So if they refuse medications, we can even ask them, okay, have you been taking some antibiotics for the past maybe 2 weeks, or have you been recently from taking antibiotics? Because if you say, are you taking any drug, maybe they can refuse. But if you ask them, okay, where are you from taking drugs, they'll be like, I've been taking antibiotics for 2 weeks for this and this condition. Okay, then family history. ask anyone in the family at home with the diarrhea. Okay, then community related outbreak of diarrhea, so you ask maybe in the community. Okay, so that's the end of the station. So that's how you usually take history. So for the social history, since we did ask where the patient stays, so there's no need of us asking again, repeating the question. So if you ask something in demographics, that's what's supposed to be, or that can also occur in social history, there's no need of you repeating it. Okay, so that's typically the questions we can ask on diarrhea. Okay, then I think we can go to the next station. So this is station 3. So you are asked to do an abdominal examination on a patient with ascites. So list the findings you would elicit during your examination. So of course, even if you are just writing them down somewhere, this is how you also write them down. So you say on inspection, you are going to say rounded, symmetrically distended abdomen with flank fullness, protruding displaced umbilicus, dilated superficial veins, abdominal stria as well. Okay, then on auscultation, so for the auscultation, just depending on what you are, on where you are auscultating from. So if you want to auscultate for the bowel sounds, you find that there will be reduced bowel movements or bowel sounds. Then that's mostly the one which will be remarkable. So there will be the bowel sounds will be reduced. Okay, so reduced bowel sounds, or sometimes you can't even hear them because of especially if the ascites is too tense. Okay, then in palpation, you are going to feel a Duffy with an almost fluctuating sensation. If advanced, it may be tense. That's on palpation. Then you can also, then on percussion, you are going to find a umbilical tympani with downwards in the flanks on supine position. Fluid through and shifting downwards are also going to be present. Okay, then that's the end of the station. But on this station, what you have to know is that when you are dealing with abdominal examination for ascites, usually we follow the inspection, auscultation, palpation, and percussion. So IAPP. So the reason why after we inspect, we go to auscultation is that we don't want to disturb the bowel movements, because remember, if you palpate, if you start with inspection, then you palpate, you percuss, you do a shifting downwards, you do your fluid through, you do your other percussion notes. Okay, you want to know whether it's tympanic or what. By the time you are going to reach auscultation at the last at the find, then what is going to happen is that you are going to disturb the bowel movements, and whatever you are going to get won't be the correct thing. So that's why if you are dealing with abdominal examination, usually follow the inspection, auscultation, then palpation and percussion. So I repeat, if you are doing abdominal examination, patient has ascites, then do inspection, auscultation, percussion, and palpation and percussion. So as we have done them, that's how you follow them up. Okay, I think we can be done with this station. Then we go straight to station 4. Okay, so for station 4, heart failure examination findings or physical findings. What can be your findings if someone has heart failure? So again, on inspection, someone, if they are in distress, they will find, you can see they will be in tachypnic, and if they have any signs of respiratory distress such as nasal flaring, subcostal recession, intercostal recession, tracheal tag, including the use of accessory muscles of respiration, may be seen. That's if someone is in distress. Okay, but if you find someone without failure, they are not necessarily in distress, then you won't necessarily see them. But when you're writing this, it's an exam setup. If you say if they have signs of respiratory distress such as, then it's okay, since you have indicated to say if that patient you're examining has the signs of respiratory distress. Okay, then For the jugular venous distension, so there will be a jugular venous distension, or there will be distended neck veins on inspection, which is of course frequently present, and as engorged neck veins. Like I said, you might find distended neck veins or engorged neck veins. Okay, so that's how the neck veins, you can ask about the neck veins. Okay, then the next thing is you can also ask is for if the skin, you can say, okay, the skin may be diaphoretic or cold, they may be gray, or they may be gray and cyanotic. So that's the things you can also note for. Then also on the lower extremities, you can find there will be lower extremity edema, which may also be noted, especially in the subacute process. That's mostly on inspection what you can see. Okay. Then on palpation, so on palpation, you can the apical beat, the apical impulse is frequently displaced laterally. Okay. Then you can also palpate for any presence of a pulse or alternance, which is alternating weak and frequent pulse, which is indicative of depression, of a depressed left ventricular function. Okay, that's so the sole purpose or the reason why you can find this examination or this sign. That's on palpation. Okay, so of course there are other things you can palpate for. Okay, then since we said maybe someone may have the total distance, you can also palpate for the chest movements, but otherwise, since this is more a specific heart failure examination, then it's fine. You can even end there on palpation. Then on auscultation, if you are going to find the wheezing or else, which may be heard on lung auscultation, and there may be bilateral basal downness. That is on auscultation. So this is now the lung auscultation. When you go to the cardiac auscultation, it may review aortic or mitral valve, valvular abnormalities such as or other abnormalities. Can be S3 or S4. It can be gallop rhythm. Okay, they can be murmur. So there can be just other differences or other findings. So the heart may be tachycardic. So in short, it's not necessarily cast in stone for the ones we have mentioned. So just depending on the condition we are dealing with, that's also how it's going to be. That's typically everything I wanted to share on this station. So that's physical examination. So the reason why we have just talked about inspection, palpation, and auscultation is that usually percussion, we don't necessarily do a lot on percussion in cardiovascular examination. But for the palpation part, you can also, if the patient had, since we said they may have a lower extremity edema, then on palpation, of course, you can also say they may also have pitting or edema or non-pitting edema. So just depending on the case that you are dealing with or what exactly you are dealing with. That's how you do the examination findings on heart failure. Okay, so that's typically what I wanted to share here. So then you think we can move on to the next station. So the next station is during a major round, your consultant asks you to examine a 50-year-old male patient. So the patient has diabetes and you ask to do a focused examination from his knees and below, bearing his diagnosis from his knees and below. Then you also have to bear his diagnosis in mind. List the things you would be looking for or focused on in this patient. So this one, it's a very good question, especially in our setup where sometimes diabetes is very challenging. So someone can come with autonomic dysfunction. So when they are in autonomic dysfunction, an examination from the knees and below is a very good one. So if the patient finds that the patient has been coming with diarrhea, is with history of constipation, urinary incontinence, then you can suspect that they may have or they have some kind of tingling sensation, then they may have autonomic dysfunction. So this examination is very important. Okay, so you can also note for any diabetic dermopathy, which are pigmented pretibial patches or diabetic shine spots. You can also note for any diabetic foot syndrome, so is there any callosities, dry skin, ulcers, xerosis, or decreased sensory sensation. So that's some of the diabetic foot syndromes. Then you can also note for any necrobiosis lipoidica, which is just chronic granulation dermatological disease, where there is a single group of film well demarcated around the erythema papules. Okay, you can also note for any bullous diverticulum, which is a eruptive blistering condition. You can also do a pinprick test. So if we find that maybe the pinprick test might be negative in the same patient, but remember, you can't necessarily use something to prick them with. It might develop into a foot ulcer, so you can just try to pinch them. Then if you find that's negative or it's reduced sensation, then you can put the same as well. So the other way to write this is to say, okay, on inspection, this and this and this, on percussion, on palpation, this and this and this. That's also how you can put them instead of just mentioning them like this. So, but you can say on inspection, you're not for any dry skin, you're not for any diabetic dermopathy such as pigmented pretibial patches or diabetic shine spots. You also note for any necrobiosis lipoidica, such as chronic, which is just a chronic granulomatous disease, where you notice for any single group of them well demarcated rounded erythematous papules. So in short, you just tell them to say these things. We are going to see them on inspection. Okay, that's how you do questions that are telling about examination. Okay, then the other thing is, the other question to be asked on this one is, says instead of examination, they might also ask you about just information. That's IEC. So information, education, and counseling. So what can you do? Someone presents with the way I was talking about. Like someone comes, they have autonomic dysfunction, they are diabetic. So what are you going to do about such a patient? So someone who has autonomic dysfunction, of course, if like I said, if they have any history of constipation, history of diarrhea, so they have diarrhea, constipation, they have an intermittent urinary incontinence. So the other thing is, information and education and counseling. What you can do is that, number one, for you on your part, you have to have a good glycemic control. Then after that, the information you're going to give them is that what is happening to their body is that they are going to have reduced sensation on their feet so they have to be putting on shoes that have hard surface. So the surface should be hard. Then on the anterior part or the part on top should be soft. Okay, and it shouldn't have any metals, especially where the toes are going to be. It shouldn't have any metals in front. So we tell them to be putting on such shoes. So they are the shoes that have a hard surface, such that if they were to step on something which might prick them, it won't prick them, in short. So because if it was to prick them, then they can't necessarily feel that. They're just going to find that they have a wound that's not healing. Okay, then after that, you also tell them to say, okay, when you're cutting your nails, don't use a razor blade. So because the razor blade just directly like that, you might cut yourself, and you might not necessarily notice there and then because the sensation is reduced. So they might just notice for blood, and after that blood, then they find that the wound takes long to heal. So that's some of the things you have to follow. The next thing is on the good glycemic control is that after the good glycemic control, you can switch them on medications so that you find the perfect medication that are working properly for them. Okay, you can even go back to a diabetic dietary advice, so you advise them again on what foods to eat and what and other things. Okay, so these are some of the information you would want to tell the patient who has an autonomic dysfunction and they are diabetic. Okay, so these are some of the things I think we can end here on this station. But remember, we are not limited to what I've just talked about. There are a lot of things you can tell someone with a diabetic foot, especially in our setup where the shoes can be hard to find. But specifically, there are shoes that are meant for diabetic people. So if they are available, then if you know them, you can just advise them to buy the same. Okay. Then for station 6, a patient presents with a cough and fever. Take a relevant history and list the questions. Don't write an essay. So you have to note for a physical OSC, you have to introduce yourself, you greet the patient, gain consent, ask about demographics, and don't forget to thank the patient after you are done, even if you have not yet finished. So starting of symptoms. They have told you the cough and fever, but they haven't told you the duration. So ask what is the duration of the symptoms. Details of cough. Is the cough productive or non-productive? Then if productive, what's the color of the sputum? Ask the amount of sputum. Any hemoptysis, or is it blood stained? So is the cough associated with any chest pains? So the other things we are talking about are associated symptoms. Okay, chest pains, the difficulties breathing. Okay, that's some of the associated symptoms you might ask. So are there any aggravating or relieving factors? Any history of night sweats, anorexia, and weight loss? Those are some of the things we are going to ask. Okay, then ask about any history of pedoedema, orthopnea, PND, breathlessness, dyspnea, dizziness, palpitations. Ask for any past medical history or any history of COPD, HIV, TB, pneumonia, asthma, or lung cancer. Then drug history, ask for any current conditions or any current medications or current allergies. Then for family history, ask for any family history of asthma, any family history of TB or TB contact. Okay. Then if they have the TB contact, then you can ask them when was that same TB contact. Okay, you might find that it's actually been 20 years now, but at least any recent one. Okay. Then for social history, ask for any history of smoking. If yes, what's the duration and number of cigarettes per day. Okay. Then for occupational history, ask where do you work. Are you an outfield worker or miner? Any occupational language. We are when we ask such a question, we want to point ourselves to say maybe this person has an occupational lung disease. So that's how you ask most of the questions when someone presents with fever and cough. Okay, that's typically everything I wanted to share on this station. But remember, the questions are not limited to what we have just talked about. You might also ask other things depending on the case that you are dealing with. Okay, because as they say, condition never studies books. Then that's how you can do this kind of examination setup. Okay, I think we can move on to another station. So this is station 7. So station 7 is saying a patient comes in with complaints of dizziness, headache, and palpitations. Take a relevant history, then list the questions. Don't write an essay. Okay, so a patient comes in with complaints of dizziness, headache, and palpitations. Take a relevant history, list the questions. Don't write an essay. So we have been given dizziness, headache, and palpitations. So for starting of symptoms, and the other thing I've forgotten to mention in all these history taking examination is that when the patient presents with a system, you have to exhaust that system during your asking in your history of presenting components. And if you feel, you also need to ask about any other symptoms related in other systems, then you have to ask them after. I have to ask them before you go to your past medical history. So in short, the review of system also can be written, but where you just don't write review of system, but just say you just ask the questions you want to ask in the review of systems. Okay. So starting of symptoms, ask about the duration of the same dizziness, headache, and palpitations. Inquire about any blood loss, any hematemesis. You have to clarify the nature of the hematemesis. Okay, melena, you have to clarify the nature of the melena as well. So other bleeding sites. So if it's a woman, then that's also also going to ask about the menses. So how are the menses? So you can even start from the age of menarche. So you more like do a gyne history. Okay, so but you can even do it after you are done with the history taking. But there's no harm in you asking instead of presenting complaint this. So you ask for the age of menarche. You ask for the menses. How are they? Are they regular or not? In how many days do the patient bleed a lot when bleeding? Okay, that's how you ask. Okay, then you also ask if it's the first time the patient is presenting like is having the headache and the dizziness and palpitation. So this is the first time you're experiencing these symptoms, or you even experienced some time back, and they even told you that maybe you had your blood was reduced. So this is how you do. You ask the questions. Okay, you ask for any yellowing of eyes. So after any yellowing of eyes, you can ask for any abdominal distension. You can ask for any swelling of lower limbs, body aches and bone pains, any history of cough, orthopnea, PND, fatigability, syncope, even body hotness. You can even ask. Okay, so that's the body hotness, history of fever, anorexia, and weight loss. Okay, is there any history of blood transfusion and history of tattoos? Okay, then past medical history, you ask for any history of sickle cell disease, any recent illnesses or admission. Okay, ask for any drug history. For drug history, ask for any current medications or current allergies. Then you also ask for any family history of sickle cell disease. Okay, then any history of alcohol, history of smoking, if yes, duration and number per day, that. Then if it's a she, regularity of her menses, like we've talked about already. Okay, so like I said, you can even ask it under gyne history, where you just put a title to say gyne history, and that's where you ask the things we are talking about. Then the other things I failed to mention was you can even ask her about how many children that she has had. She has had any operations, any past surgical history. So like there are a lot of things to ask here. So as the patient has any past surgical history, so if they had when was the past surgical history and for what? If they have children before, how many children, and when last did the patient stop breastfeeding? So breastfeeding is also an important question. So when last did they stop breastfeeding? Okay, so that's some of the things you have to ask. Then apart from that, you can also ask for the diet. So how is the diet like? How many times per day do they eat? Okay, and apart from that, you can ask even what do they eat exactly, because you might find someone says okay we eat, but okay, how many times do you eat, and what foods do you eat when that they don't even eat? They have inadequate intake or inadequate dietary intake. Okay, so that's some of the things you have to know or you have to ask about such a case. Okay, then for station 8, so for station 8 you have to, so for station 8 it's saying a 45-year-old female patient presents to the outpatient department with yellowing of eyes for of 7 days duration, List focused questions you'd ask the patient in your history that could help you arrive at a diagnosis. Okay, so that's the question. So what questions are going to ask that's going to help you arrive at a diagnosis? Someone's come with a yellowing of eyes for 7 days. So of course, demographics. For demographics, so you always begin with demographics, regardless of whether I've received demographics or not. You, when it comes to you, writing and especially if it's a long case or what, you always start with demographics. Ask about the residents. Then if you haven't asked demographics, ask them in the social history. There's no harm. Okay. Then residency, under demographic, ask about any residency, country of origin, any history of hepatitis virus or hepatitis B virus if you want to be specific. But just say any history of hepatitis, any history of malaria infection. Okay. Any history of travel. So that's some of the things we're going to ask. Then presence of going to ask for any pairs too. So what's changed with your bowel? What's changed with your bowels? So do you have any pairs too, or any changes with your bowels? Then any itch skin, any dark urine. Have you had any urinary symptoms that were like is the urine dark, or maybe any other urinary related symptoms throughout obstructive causes or obstructive jaundice as they call it. Okay. Then after that, you can ask any recent sexual activity. Okay, so even ask if whether the patient is homosexual or not. So it's a very good question. Okay, then any blood transfusion or infusion of blood products. So still the same hepatitis B, C virus. Okay, we just want to see if they may have any hepatitis. In short, ask about the alcohol consumption, not the type, amount, and frequency of the same. Okay, then ask for any drugs taken in the previous 2 to 3 months, any recreation drug use, specifically IV drugs used, if considering bloodborne disease. Many drugs cause jaundice. Okay, so especially the IV drug abuse, then you have to definitely you just have to ask, you just have to remember. Okay, so then these are some of the questions we are going to ask. Then you also have to ask, have you been unwell recently? Ask for, have you noticed any other associated symptoms or any history of fever, general body weakness, headache, palpitations, dizziness, abdominal pain, yellowing of the eyes? Okay, and do you have any pre-existing medication? Do you have any pre-existing so it's supposed to be medical condition, not medication condition, any medical condition? Is there any previous hospital admission? So we are now on past medical history. So remember, the reason why we are doing them as past medical history, what and what, is that for you to have an idea on what we are talking about. But when it comes to an actual exam, or if it comes to long case, you yourself are the one who has to bear in mind that, okay, where I've reached now is the past medical history. Then you ask the patient to say, okay, do you have any pre-existing medical conditions? If in previous hospital admissions. But for jaundice, you can ask if they have any pancreatic conditions, or if they have any pancreatitis, any pancreatic cancer, if they have a macromatosis. Like, those are some of the questions you ask under the pre-existing medical conditions. Okay, that's the thing. Okay, then any medication that's done, any medical conditions that, so I don't know why this was medications. So in medical conditions. So in medical conditions that run in the family, including cancer, even hemochromatosis can be asked, spherocytosis can be asked. So you have to ask questions that can be tailored to the yellowing of eyes. Okay, so that at least you rule out surgical causes. So, okay, so any recent surgery on the biliary tract for carcinoma. So not only the biliary tract, so it's not on the biliary tract. Can I ask for any surgery on the pancreas, any pancreatoduodenectomy, okay, and pancreatic surgery, okay, biliary tract surgery, okay. So that's how you ask about the surgery cases. Then ask for any travel history, okay, because of want to rule out them having hepatitis A and E, and of course as well as malaria. Then ask for a melena. So is there a melena, hematemesis, or hematochezia? Those are some of the things you have to ask, okay, even hematochezia, okay. Then that's some of the things we have to ask, because we haven't exhausted everything. But remember, these are some of the things that should point you toward whether you are dealing with surgical jaundice or medical jaundice, or obstructive jaundice and non-obstructive jaundice. So I think we can end here on this station, then we go to the next, okay. So station 9 is saying a 22-year-old male HIV positive patient is found to have a large right-sided pleural effusion, and the left side of his chest is normal. Outline the findings you will get when you do a chest examination on this patient. Okay, so for the chest examination, we have to follow the IPPA, which is the inspection, palpation, percussion, and auscultation. There is no arm. Okay, so on inspection, there may be asymmetrical chest expansion, can be a trail sign on the left side, on the left sternocleidomastoid muscle. There may be a tracheal tag. There may be features of respiratory distress. So which ones are features of respiratory distress? So there may be use of accessory muscles. There may be nasal flaring, intercostal and subcostal recessions. That's on inspection. Then after inspection, then on palpation, the trachea may be deviated to the left side, since we are saying the patient presented with a large right-sided pleural effusion. That's why I said deviated to the left, because where there is volume expansion, the trachea deviates away from the pathology. Hope you are remembering your basics. Okay, so that's on palpation. The trachea may be deviated to the left. Then there may be an asymmetrical chest expansion. So after you put your hands on the chest, find that there may be asymmetrical chest expansion. Okay, then there will be a decreased tactile fremitus on the right. Then there will be an increased diameter on the right as well. Okay, then on percussion, so on percussion, there may be a stony downness on the right. So on the right side there may be a stony downness, which is denoting the pleural effusion. Okay, then on auscultation, so in auscultation there may be reduced air entry on the right side. There may be reduced vocal resonance. There may be diminished breath sounds on the right. So there may be diminished or even absent breath sounds on the right. Okay, so those are some of the things you usually follow on pleural effusion, which is again, this is also another common question you might be asked, because pleural effusion is actually common. So you have to know your examination findings. So it's not only that they might tell you to examine someone, or you might write down your findings on a patient with a pleural effusion. So that's how you write them down. You say on inspection, palpation, percussion, auscultation. Okay, especially the stone downness on percussion, that's very distinctive. The palpation, the trachea deviating to the left, then they know that, okay, this, at least someone knows what they're doing, they have studied. Okay, I think that's where we can end on. We can even go to the next station. Okay, but before we go, just remember that don't master things, know them. So the reason why I'm saying this is because you might be asked another question, then they change this to left-sided. So they change to left-sided. So that's why I was explaining that on the trachea deviating to the left, it's not because you always deviate to the left, it's because this patient has a large or a massive right-sided pleural effusion, and due to the if volume expansion, that's why it has deviated to the left, away from the pathology. So if they were to change and say right, left-sided, then left-sided is going to be elsewhere, because that's how it should be. That's how volume expansion works. Okay. Then station 10, you can this is station 10. Then it's saying a 35-year-old lady present with headache for 2 weeks. Give relevant history. Then you list the questions. Don't write an essay. So location of headache. So are there any generalized or localized? So location of headache, is it generalized or localized? Can you point to where you experience the headache from? So remember, like I said, the demographics, you can start the demographics, it's okay. Okay. Then timing of headache, did it come suddenly or gradual? Okay. Is the headache intermittent, or does it come and go, or is it constant? So now would you describe its character? Is it throbbing, pounding, or piercing? Okay, so whenever you're dealing with pain, whether it's chest pain, it's the same thing. Okay, the next thing you have to ask, does the headache spread elsewhere? Okay, then are there any alleviating factors? Okay, does it go when someone takes painkillers? So that's what we can even ask. Okay, because any aggravating factors such as sound, light. Okay, then the other questions you might ask is are there any associated symptoms such as seizures, fainting, visual changes? Do they wear glasses? Any neck stiffness, fever, nausea, vomiting, or ask for any projector vomiting, ask for palpitations, light, or is there light-headedness, or the pain is too severe. Then for dizziness, ask for dizziness, photophobia, any rash, weight loss, or sleep disturbance. Okay, there's some of the other things you ask. Then for drug history, are you currently taking any prescribed medications or over-the-counter treatment such as antihypertensives, or meaning the infedpine can give someone headache? Or that's some of the things you have to ask. Okay, past medical history, ask for any HIV, migraines, hypertension, anemia, and recent head trauma. So ask if they have been told to say they have anemia. Okay. Then for the hypertension, if they say yes, they have hypertension, you have to ask about the drug. So that's why I usually prefer the past medical history one comes first, then the drug history follows. Okay. Then if they say they are hypertensive, you also ask them if they are compliant with the medication, and that's how you actually ask. Okay. And if they are compliant, even ask them about the doses for the same treatment. Okay, are they compliant? Okay, even for the HIV, it's the same thing. If they say they have HIV, then ask them for how long. Okay, if they tell you for how long, then ask them for the medications they are on. So are you on any medications? Then if they say yes, we are on medications, or we some on medication. If they know the regimen they are on, they can even tell you the same. There is no harm. Okay, then ask if they are compliant, so that you try to rule out any CNS or eyes. Okay, it's a very important question. Then for family list of migraines, you can ask for any family list of migraines. Okay. Then next, you can ask for social history. If the patient smokes, any history of smoking, the type, amount used, any alcohol, the frequency, type, volume, any recreational drug use. So these are some of the things you ask. So then what is your current occupation as well? Okay. Then that's the end, or that's some of the questions you might be asked, or that's some of the questions you ask on a deck for such a duration for 2 weeks. Remember, for 2 weeks, 2 weeks is a long period. So usually, if the patient tells you they are HIV positive, then start thinking of other causes such as the CNS or eyes. Okay, that even elicits that's why we're even eliciting for the projectile vomiting, any fevers, and for how long, neck stiffness. Okay, that's why we are eliciting for those. If they tell you they are not, then of course you still continue the same. You ask about any other symptoms. Okay, so let's move on to the next station, which is station 11. Which is saying a patient presents with lower limb pain and swelling on the left leg after 2 days of a long bus ride. He is obese and smokes. Take a focused history. Okay, so for this one specifically, you can start with demographics. So any of the stations we are doing, you always start with demographics: the name, age, occupation, residency. Okay, that's like I said. Any examination that you have been taught, always start with demographics. So remember, even if we leave out the demographics, just bear in mind to say demographics are supposed to be number one. Then after demographics, that's when you now ask the presenting complaint, especially the duration, if you have not been given. But if the duration has been given, then you go to the issue of presenting complaint, where you ask, is the pain associated with work, or is the pain in both legs? Okay. Then what are the relieving and aggravating factors of the pain? Is the patient experiencing any fever? Are you experiencing any fever? Any history of or ask for any if they are not experiencing any fever there and then, you can also ask them for any history of fever. So were you wearing tight shoes on the bus ride? So these are some of the things you ask. So were you wearing tight shoes on the bus ride? Any other associated symptoms aside the lower limb pain? So any swelling as well. So is there any limb swelling? Okay. Then ask for the right leg. So since in the history we have been given to say the swelling of the left leg after 2 days, so we can ask if the right leg was also swollen at some point. Okay, if there's not, or if it was, you can also ask for any other swellings as well. So maybe, or where exactly is the swelling ending from? Since we have been told it's the left leg swelling, so where is it reaching exactly? Okay, is it reaching all the way up to the thighs and the knees, the ankle? Okay, that's how you usually ask. Okay, so has this happened before, or has it happened to anyone else in the family? So these are some of the things we usually ask about. Okay, the next is we can ask for if it has happened before, what was done to solve the problem, and did it help? Okay, then any recent trauma to the leg? Okay, did you experience any trauma to the leg, or did something pierce you, then you just neglected it, or you didn't do anything about it because you are not bleeding? Okay, so does the patient or any family member suffer from any of the following: diabetes mellitus, hypertension, epilepsy, tuberculosis, HIV? So this is past medical history and family history. But like I said, you yourself, you are the one who has to bear in mind to say, what I'm asking is this, and what I'm asking is this. Okay, that's how it is. So is the patient on any medications? If yes, what kind? Okay, then does the patient drink? If yes, what kind of alcohol and frequency and how much? Okay, and then on smoking, you can ask for the type, amount used, sparks or sticks per day. Okay, and then before we go to the next station, you have to understand that these are just some of the things you can ask. So someone presents with unilateral limb swelling, so that's called unilateral limb swelling. So there are a lot of questions to ask when doing unilateral limb swelling. Do not be limited to what we have just talked about, but this is typically what some of the things we can ask on unilateral limb swelling. Okay, so that's the end. I think we can move on to the next station now. Okay, so this is station 12. So a wife brings her unconscious husband to the emergency department, claiming he has been convulsing. To take a relevant history. So of course, demographics, name, age, occupation, residency. So how does the wife describe the convulsion? So is this part of the body, or is it the whole body? Okay, so this is a case of where we're asking about convulsion. So convulsing or fits or seizures, you have to know that there are also questions for you to ask specifically for seizures. So we have to bear in mind that whatever we are going to discuss are things you can ask when someone presents like this. Okay. So how does the wife describe the convulsions? Was it part of the body, or is it the whole body? Where the arms and legs both involved, the head involved? Okay. So during the convulsion, did he fall down? Okay. Then if he did fall down, then you can even ask where exactly did he hit himself anywhere. Okay. Then ask what was he doing before the convulsion. So did the husband mention having experienced any odd visions? So odd visions, any tastes or smells before the convulsion episodes. So here we are more like trying to find out if there was any pre-ictal warnings or any auras as we call them. So we are trying to list for auras. So remember that's that, and they are common in where when someone was having they are not having it, but these ones are common if it wasn't a generalized tonic if it wasn't a generalized seizure, or if it was a generalized seizure, then maybe it was a it is a partial with a secondary generalization. That's how it usually is. Okay. Then what did he do during the convulsion? And then what did the husband lose consciousness after the convulsion? Okay. The next is you can ask did the husband experience fecal or urinary incontinence? Did the husband have any memory impairment after the episodes? But before the episodes, apart from you asking fecal urinary incontinence, you can also ask for any tongue biting. You can ask for a lot of other conditions as well, other things such as tongue biting, any secretions. Okay. Then did the husband have any memory impairment after the episode? Was there any recent injury or trauma? Then how did the husband feel after the convulsion? How long did it take for him to get back to baseline condition? Okay. Then how long did the convulsion last? Then how many times did he convulse? Okay, so how many times did he convulse? Is there anything known to precipitate the convulsions, or any non-precipitating factors, or any non-precipitating things that we might think of? Okay, so that's how you ask. Does the patient eat pork or poorly cooked meat? So the reason why usually we're asking this is because we want to rule out any condition that may be related to the patient eating pork, any neurocysticercosis. Okay. Then is there any history of fainting, blackouts, or seizures in the past as well? Okay. Then those are some of the things you ask. Then you also ask if the husband or family members have history of diabetes, mellitus, hypertension, epilepsy, TB, and HIV. Okay, there's some of the things you usually ask about. Okay, then ask if the patient has had a similar illness before, or any recent illness. Then did the husband complain of any other symptoms that day or recently before the convulsion? So meaning, did the husband say, okay, he has been having fevers, headache, nausea, vomiting, dizziness, etc. So that's especially the headache or the fevers. So that's how we usually ask them. So was he complaining about this? Okay, so we're trying to elicit anything that might have triggered the seizure. Okay, any presence of warning symptoms, or was there a warning signs, or the aura we are talking about? Okay, then is the patient on any medication? If yes, what kind? Okay, then does the patient drink? If yes, what kind of alcohol and how much? Okay, then does the patient smoke? If yes, what kind and how much as well. Then ask the wife if they have anything else to tell you. So that's how you ask about ask history of convulsion. So it's that's how you usually ask for history of convulsion. But know that they are not limited to what we have just talked about. There are a lot of questions to ask for seizures or convulsions. Okay, at least what we have asked is sufficient enough for you to come up with something. Okay, then station 13. A 25-year-old girl presents with episodes of syncope. Take a history and ask important questions that will enable you to make a diagnosis. So list the questions, don't write an essay. So demographics, the name, age, occupation, residency. Then after that, then onset and duration of the fainting and frequency as well. Okay, any events, what were the events before, during, and after the syncope episode? Okay, then position of the patient at the time of syncope, where there was the patient walking, seated, standing. So how did he fall? Did it hit himself, or did she hit himself? Did she hit herself anywhere after falling? Okay, then collateral history of abnormal body movement during loss of consciousness and possible injury. So usually when someone faints, you have to ask for collateral history. So who were the people present after the patient had fainted? So ask them, was there any body movement during the loss of consciousness? You are trying to rule out it being a seizure. Okay, then if they say no, then you can still ask them any possible injury. So did she fall and hit herself anywhere after falling? Okay, so you just ask the collateral, ask someone who might have been present after the fall. Okay, then ask for any presence of warning symptoms such as dizziness, nausea, profuse sweating, visual disturbance, or ringing in the ears, which is tinnitus. Okay, tinnitus. Okay, then we also ask other symptoms such as precipitating factors such as exertion, swallowing, or bowel movement. Okay, or the patient may be overworking. Any associated symptoms such as palpitations, tachycardia, panic attack, plus hyperventilating. Events preceding syncope. So was the head turning or neck? Turning? Okay. Any micturition, so it's supposed to be turning. Any micturition, shaving, and cough. Any tongue biting. Okay, these are some of the things you have to ask. Okay, then so for the collateral history, did the patient change color? So do they have any? So on history, you don't have to ask for any color. So you can just say, was the patient pale? So say pale. Did the patient turn blue? So since someone can know the cyanosis, so since we're asking someone, so did they look pale? Did they turn blue at some point? Or did they seem or appear drowsy, confused after the loss of consciousness? Okay, then ask them. The next thing we can ask is how long did it take for them to fully recover or to come back to full baseline? Okay, is there any family history of sudden death, heart problems, seizures, and epilepsy? Okay, drugs. So is patient maybe using beta blockers, digoxin, antidepressants, or antiarrhythmias? Okay. Then for the past medical history of DM, can ask for the past medical history of DM, hypertension, any heart disease, any epilepsy, even anemia. You can ask for any past medical history of anemia. Okay. Then past surgical history or any pacemaker insertion or cardiac surgery. Then any history of smoking, alcohol, or recreational drug use by the patient. So these are some of the important questions you might ask when someone comes convulsing. Okay, so for this specific thing we are talking about, that's the other things I think we can end on. We have asked most of the relevant questions. Then for the station 14, so this is another station, so we just see the question. So a patient presented to the A&D with cough and fever. Take a relevant, take a history and ask important questions that will enable you to make a diagnosis. List the questions, don't write an S. So the question is, someone has come with cough and fever. Okay. So for cough and fever, again, demographics, name, age, occupation, residence. Then the duration of the symptoms. Okay, what's the duration of the symptoms? The nature of the cough, is it productive or non-productive? If productive, what's the color, blood, and amount? If there's blood, then what's the amount? Okay. And then presence of night sweat, sweat loss, and anorexia. Any presence of other symptoms such as chest pains, shortness of breath, osopnia, PNDs, fatigability, palpitations, leg swelling. Okay. As for any history of TB, asthma, COPD, hypertension, and HIV, and that's past medical history. Then for drug history, ask if the patient has been on any drugs recently. Okay. Family history, ask for any family history of asthma and then TB contact. Okay. Then for ask for any history of smoking or alcohol intake. So this one, since we had the previous station where we asked about, where we had someone who presented with cough, fever, and chest pains, so that's where we can end here. So since we know what to ask, any history of body hotness, what and what not, so we have already done this question on the previous one. So there's no need for us to exhaust a lot of things. So these are some of the things we can ask. Okay, but remember, more we are exhausted in the questions that came with together with the chest pain. Okay, so any associated chest pains and whatnot, that's also the reason why I'm saying we usually exhausted this. So okay, so let's move to the next station, which is station 15. So for station 15, saying a patient presents with a swollen abdomen and parotid enlargement. Take a history and ask important questions that will enable you to make a diagnosis. So list the questions, don't write an essay. So duration of abdominal swelling and parotid enlargement. Ask for any history of swelling. Ask for any history of swelling of feet, face, yellowing of skin, eyes, palms, fever. Ask for any fever, anorexia, weight loss. Ask for any history of hematemesis. And ask for any history of AIV, drug abuse, tattoos, blood transfusion, bathing in streams or in dams, any history of hematuria. So for the past medical history, ask for any HIV, TB, and any other medical condition. Okay, so ask for any history of alcohol intake, the duration, the type, the amount. Go to your social history, ask other related symptoms. Okay. So is the patient able to go to the toilet? If they have any associated abdominal pains, diarrhea, there are a lot of questions to ask for a swollen abdomen and also exhausting the parotid enlargement. Okay, is the patient having any symptoms associated with the parotid enlargement? Okay, then as associated symptoms with that. Okay, so that's some of the things you might ask on this condition. Okay, since we are dealing with two symptoms, you have to exhaust them further and differently. Okay, I think we can end here on this station so that at least we will make progress. Okay, so for this station is saying a 28-year-old man presents to the emergency department having been unwell for the past 6 weeks or so. He has been on TB treatment for the past 6 weeks. He complains of poor appetite, tiredness, and is particularly concerned with his eyes have turned yellow. On examination, he has jaundice and a palpable mild retained liver. Easily liver function or liver enzymes are as follows. The bilirubin is 185 and the normal range is 3 to 17 micromoles per liter. Then the AST is 1610 and the normal is 5 to 35 international units per liter. Then the AST is 1635 and the normal is 5 to 35 international units per liter. Then the ALP is 220 and the normal is 30 to 300 international units per liter. Then the GGT is 50 and the normal is 11 to 51 international units per liter. Then the albumin is 35 to 38 and the normal is 35 to 50 gram per liter. Then the INR is 1.5. Okay, so what further questions are you going to ask? So this is a short one. Ask for any HIV status, ask for any drug history, so drug name and dosage, and also as well as compliance. Ask for any history of alcohol intake, ask for any recent history of travel or malaria. Then also ask for any GIT or upper respiratory tract symptoms. So the GIT, ask for any abdominal pain, nausea, vomiting, diarrhea. Okay, for the upper respiratory tract, ask for any history of a flu. You can even ask for even just the lower respiratory tract, it's fine. You can ask for the cough, ask for other related symptoms. Okay, the patient having cough, having night sweats, having fevers. Okay, so that's some of the things you are going to ask. Okay, then you can also ask whether the patient is homosexual as well, since it's also one of the risks. Okay, and you can ask that. Okay, then next session is saying Jane, a 35-year-old patient, a patient teetotal, meaning they have never taken alcohol before, was commenced on antiretroviral therapy a year ago. So she presents to the admission ward complaining of severe body weakness, palpitations, and headache. On examination, she is found to be febrile to touch and very pale. So what pointers in the history would help you elicit the cause of the anemia in this patient? Okay, so what pointers in the history are going to help you? So 5 marks. So what type of drugs is she taking? HIV regimen she's taking. So how's the compliance? Diet, is she taking enough proteins, iron, etc. Okay, LMP, what's the last menstrual period? How regular are the menses? The age of menarche as well. These are very important things. The number of pregnancies and mode of deliveries. Then is the patient currently breastfeeding now or what? So like we said, this is very important when a woman presents with complaints of that you might thinking of anemia. You ask a lot of questions as compared to a male. Okay, ask for any presence of chronic illnesses such as TB. Does the patient ever taken alcohol before? So the reason why we're asking again, even if they have said teetotal, is that someone might say I've never taken alcohol before, or I don't take. If you ask them when last, they'll be like, you know what, maybe 2 weeks ago, that's when I stopped. But they told you they have never taken, so that's how we can just ask them again, though it's going to annoy them. Okay, is she bleeding from anywhere? Any history of blood in urine, history of blood in stool. Okay, then what features on examination would help in identifying the anemia? Okay, so for the features, you're going to can check for any chloronychia, angular stomatitis, beefy tongue, paresthesia, reduced power, reduced sensation, abnormal balance, and ataxia. So these are some of the things you can ask. Then we can go to the next station. See station 18. So for station 18, saying a 42-year-old patient presents with fever for 3 days, weight loss, increased thirst, and passing a lot of urine. A respiratory review is unremarkable. She is not hypertensive and has no significant medical or surgical history. Okay. Then what other relevant questions would help make a diagnosis? So history of diarrhea, dysuria, increased hunger or appetite. Ask for any past medical history of HIV, diabetes, and any recent illness. Also ask for any family history of diabetes. And then drug users for any use of protease inhibitors or any other drugs such as anti-hyperglycemic drugs or diuretics. Okay. Then ask for any alcohol, smoking, and also the diet. So this was a short one, so since I'm not going to ask a lot of questions here. And finally, this is some of the bonus questions where you can get to test yourself on. So the question, so you can even answer them in the comment section. So take a relevant test in a patient presenting with hematemesis in the emergency department. So this is take history for hematemesis, that's 10 marks. So an 21-year-old male presents with the OPD with a history of fever, sore throat, and cough for 7 days. Outline the history we wish to elicit 10 marks. Okay, then the JK male 52-year-old generally has not been feeling great for a fortnight and loss of appetite. In getting further details in the history, list 10 relevant questions you would ask him. Okay, outline your examination finding in a patient with cirrhosis of liver. So these are some of the bonus questions you have to test yourself on, and have a good fortune ahead. That's the end of the tutorial, and thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification, and of course see you on the next tutorial video.